Hi, I'm Eddie Strivens. I'm a geriatrician and clinician researcher in far north Queensland and clinical lead of the Healthy Ageing Research Team. I'd like to start by acknowledging Aboriginal people and Torres Strait Islanders as this country's First Nations people and recognising them and their communities as traditional and cultural custodians on the land in which we work to provide safe and quality healthcare. I'd also like to introduce you to the Torres Strait, of which more later, and our Healthy Ageing Research Team made up of researchers based in Cairns, Cape York and the Torres Strait and beyond. I'd also like to thank the traditional owners of the land on which the research took place, as well as the community's elders and healthcare providers who contributed in every way to this body of research. This is far north Queensland, which is the pointy bit at the top of mainland Australia and is situated over an area of nearly 400,000 square kilometres, but with only 280,000 people in it, with 95% of that population within an hour of Cairns. The Torres Strait is the collection of islands up at the very tip and situated around a 2-hour flight from Cairns, and made up of 18 islands and 5 Northern Peninsula communities, with Thursday Island as the main population centre. So, the Healthy Ageing Research Team has around a 20 to 25 year history of working initially as a clinical service delivery, so that's around outreach geriatric medicine, but through that and with community identifying research questions that were important to those communities, health care providers and the individuals within those communities, and answering the questions that they have in a collaborative manner. And that's really our local model of participatory research, that these research questions are not developed in an academic centre and the researchers fly in, do their research, fly out, publish their papers and are never seen again. These are research questions that are truly community driven and informed. They're questions that community see as a priority and want answered. Engagement on this has to be truly meaningful. It's not just a question of coming in with your protocol and getting it ticked off. It's actually about developing the architecture of your research project with community and being willing to adapt and change according to those needs. And combining with research that true reciprocity, looking at training, education and post-study support, not again just papers. And I guess what we've found successful as clinician researchers is combining both the research effort but with ongoing clinical service delivery. This is perhaps best illustrated by the work we did in looking at the prevalence of dementia in the Torres Strait. Now, this has a background in clinical service delivery. We initially came to this research question after our outreach trips and community and health providers noticed there was a higher level of cognitive impairment within the community than we'd expect to see, and yet we didn't have the clinical assessment tools to both make the diagnosis and look at progression and follow-up. This led to the development and validation of a cognitive assessment tool, and from there a dementia prevalence study. But this was done very much as a rolling program. We started small with a pilot program. We worked with community to adjust and develop any of the research tools. Then with the backing of community, applied for larger grants to enable the prevalence study to be rolled out across every populated island and community in the Torres Strait. And when we look at methodology of consultation, community consultation and feedback needs to be multimodal. It isn't just a question of the participant information sheets. We've found different methodologies such as community radio, health action days. We developed a healthy ageing calendar as well, have been as effective as any consent and information sheet. And also through this has developed a number of projects that have been developed with community and by community. And at the moment are working on developing a framework of healthy ageing. And this was very much flipping the traditional paradigm of looking at risk factors by actually looking at, from feedback from community, they wanted to concentrate on What are the strengths-based rather than deficits-based approach? What are the things that make us age successfully rather than concentrating on the more pejorative risk factor term? And is a good example of how research was changed according to community priorities. So in the end, the lessons learned are really that any research topic has to be clinically relevant and driven by the community. We need to look at that rolling program of consultation engagement, training, research, education and clinical service delivery, and not just end it when the funding for research ends. It's also important, and an important factor of what we're doing with this is bringing on First Nation researchers and looking at building capacity both within the research and clinical communities to support a handover eventually to community control and look at translating those research outcomes to true clinical service delivery. Thank you all very much.